The organizers for making me a part of this esteemed conference. So I will be talking on next 15 minutes on brain death certification in neonates and pediatric patients. So first of all, why pediatric brain death certification? Why we need to talk about it? So when we go into the data, which I think we have been discussed multiple times since morning, there has been more than 2 lakh Indian patients who are requiring transplantation, and there is a huge gap between the number of patients requiring transplantation and organ donors. And if we go into the pediatric data, I think it is even more depressing, with more than 1 lakh plus awaiting organ transplant. 25% of the children who need to transplant are still under 5 years of age. So there are thousands of children who are waiting for organ transplant with a hope to get a new life. And we do have many success stories outside India, and these are some of the happy faces who's received transplant. So, but why pediatric brain death certification is more difficult in adults? So there has been inconsistency in protocols worldwide, as with both ethical and legal controversies. The pediatric brain actually is an immature brain which is in a developing process. Usually newborns and infants, they have open fontanelles in infants. With open fontanelles, it prevents its in rise of the intracranial pressure, and this makes the assessment of neurological examination quite difficult. Moreover, the brainstem area is more resistant to hypoxic injury, so often they do not get the injury and they recover fast. So as Sir said initially, there is higher chances of recovery of neurological function even after a brain injury. So we need to be extremely cautious when we are dealing with pediatric patients of brain death. The next thing, most of the sick patients who come to us, newborns and infants, most of them have received sedatives. And I have to mention the most common sedative, anti-epileptic that we use is phenobarbital, and it has a very long half-life of 100 hours. So we need to wait for quite long so that the effect weans off and we could elicit the neurological examination. So due to this, you need to perform multiple examination. You need to have a longer observation period in order to evaluate the child for brain death. And again, there has been neurodiagnostic tests which are well validated in adults, but in children we have lack of validation studies and also there is difficulty in interpretation of the neurodiagnostic test. So coming to the historical perspective, the first criteria for brain death was given in adults in 1968 and in pediatric in 1987. Then it was revised in 2010 and 11, and now in latest in 2023 we have the revised updated guidelines both for pediatric and adult given by American Academy of Neurology and AAP. So this is the latest consensus guidelines which was recently published in Neurology in 2023. So what is the definition of brain death, or I would rather call it death by neurological criteria? Is permanent unconsciousness and loss of all brain stem function coupled with the inability to breathe in the setting of an adequate stimulus. Brain death is quite a traditional term that all of us have been using, but now most of the consensus guidelines prefer to use death by neurological criteria, which seems to be more appropriate. So what are the principles of brain death? There is irreversible cessation of all functions of entire brain, including the brain stem, resulting in coma, brainstem areflexia, and apnea. Brain death cannot be determined less than 37 weeks of age because the brainstem reflexes are not completely developed. A patient who meets the criteria of DNC may also be a candidate for organ tissue or donation. So to avoid conflict of interest, the clinician who has been involved in DNC determination should avoid any direct involvement in decision making regarding organ donation. And before we evaluate for DNC, we must exclude the confounders which could be present, as these confounders are irreversible causes of brain death such as hypothermia, hypotension, CNS sedatives, antiepileptics, any facial trauma, ocular trauma, metabolic derangements, neuromuscular diseases, and pharmacological paralysis. So who can perform DNC? Mostly it is pediatric intensivist, neonatologist, neurologist, any neurosurgeon or anesthesiologist with critical care training. But the latest guidelines say it is not, these people must be adequately trained and competent enough in accordance with the local laws and institutional standards. So we need to have a supplementary education program which can include a well-designed and online in-person training course. So what are the prerequisites to determine DNC. First of all, we should have a recognized cause of coma, and neuroimaging could help us with that. The most common causes are intracellular hemorrhage, hypoxic brain injury, and sepsis or meningitis. But we need to rule out the reversible mimics in children. The other prerequisites is you need to maintain adequate temperature, you need to maintain adequate BP. If the baby has received sedatives, you need to check for the drug levels, allow at least 5 elimination half-life before conducting the exam, and especially we need to check for phenobarbital level, which should be less than 5 microgram per milliliter. Rule out other metabolic and endocrine derangements, and if the child has received CPR or any acute brain injury, you need to wait for 24 to 48 hours before going for neurological examination. So the ultimate diagnosis of brain death, there are 3 components: neurological examination, apnea, and ancillary test. And newborn, that is more than 37 weeks of gestational age to 30 days, it requires at least 2 clinical examinations by 2 different clinicians, 2 apnea tests which could be performed by same clinician, and the duration between 2 examinations should be 24 hours in newborns and 12 hours in infants or other bigger children. Ancillary test is not mandatory, it is required only in special situations. So when we go for clinical evaluation, which is the most essential part of DNC evaluation, there must be absence of higher brain functions, no motor response of head, neck, and extremities even after application of noxious stimuli. And the brainstem functions should be completely absent, which includes the pupillary light reflex, corneal reflex, oculovestibular reflex, cephalic reflex, and gag reflex. But in newborn, we need to consider 2 other reflexes, that is the sucking and the rooting reflex. If the patient with brain death is having spinal reflexes, sweating, tachycardia, normal BP, or absence of diabetes insipidus, still it is included as brain death. And the following conditions like seizures, any extensor flexure response, or decerebrate corticate posting should not be, is not compatible with brain death. Now coming to apnea test is quite similar to the adults as well, so I will not go into the detail of that. But we just need to know that the tracheal insufflation process which is carried out in adult is not indicated in apnea in children. So in children, when we perform apnea test, we need to connect it to either CPAP or TPs, deliver 100% oxygen, and then perform the apnea test. If there is no respiration, arterial pH is below 7.3, PaCO2 is more than 60, and still if there is no efforts, then we consider apnea test as positive. During the procedure, if there is hypotension, desaturation, or any cardiac instability, you need to abort the test. Now coming to the ancillary test for brain death. Ancillary tests, again, they are not mandatory, but they are used when your neurological examination or apnea test cannot be performed or the findings cannot be interpreted adequately. They are used in specific situations. So the battery of cerebral ancillary tests are which indicate cerebral blood flow, and one is to test the electrophysiological function. Among these, your digital subtraction angiography, radionuclide angiography, and transcranial Dopplers are indicated in adults. But whereas in pediatric, transcranial Doppler is not done, and in fact EEG is preferred. So EEG was mandatory initially and has been long used as an ancillary test, but nowadays I think even in adults it is not much indicated, but it is suggested in pediatric age group. But along with EEG, we need to supplement it with evoked potentials, because EEG only sees the cortical part and does not see the brainstem part. So supplementing it with evoked potentials helps you to assess even the brainstem part. Then the digital subtraction angiography, which is actually considered the gold standard for ancillary testing. It has highest sensitivity and specificity. Here we can see there is complete absence of intracranial flow, but in this you need to transport the patient. There is risk of contrast nephropathy. It is an invasive test requiring significant skill. But this is indicated both in pediatric as well as adult. Coming to radionuclide imaging, again this is indicated for both in children as well as pediatric. But only cons is it again does not give you much information about posterior fossa visualization. Here we can see there is absent activity in the brain dead patient. Now coming to transcranial Doppler, I think transcranial Doppler is again a suggestive alternative to cerebral angiography and radionuclide studies in adults. I would say this is quite a useful test as it is non-invasive, can be done bedside, it is inexpensive, can be performed anytime, and it is one test which can assess both your anterior as well as posterior fossa. Here we can see there is systolic peaks, there is reversal of diastolic flow, and this can be seen in brain dead patients. But sadly, cerebral blood flow may be detected still in clinically brain dead patients because they have open fontanelles, and there is no validation study in pediatrics. But this is something that we can have validation studies in pediatrics, and we can involve it as one of the ancillary tests because this is something that is very feasible in our setting. And transcranial Doppler is something that we have been using quite frequently in our day-to-day practice for sick patients, and it is quite helpful when we need to counsel the patients regarding the poor outcomes, especially in HIE cases. So when I summarize the overall differences between adult and pediatric neonatal DNC, the number of minimum examination required is 1 in adult, whereas in pediatric you require at least 2 minimal examination, 24 hours apart in neonates and 12 hours apart in pediatrics. Apnea test, again single in adult and 2 in pediatric. It is the same procedure as adult, but the tracheal insufflation process should not be followed. The preferred ancillary tests in adults are 4-vessel cerebral angiography, radionuclide studies, and transcranial Dopplers, whereas in pediatric it is radionuclide studies along with EEG with evoked potentials. Implications of future perspectives. I think the most important part is awareness. When we talk about brain death, I think there is complete lack of awareness in the pediatric fraternity. The awareness is extremely low. Even when we are dealing with patients of brain death, our aim is just to counsel them for the parents, for the outcome. And we do not have the larger perspective that these patients could actually be your potential donors. And I would say not only in private or government and many centers that we've worked in pediatric, this awareness is completely lacking. So I think with organizations like ISOT and this awareness could be increased. The next is qualifications of the examiners. Many people performing for brain death evaluation, they need to be adequately trained by proper workshops or inline trainings. We need to have more validation studies for ancillary testing, especially like transcranial Dopplers. And further, we need to have guidelines and recommendations, hospital policies to provide optimal care. Controversies, yes, they are always existing with brain death. The most important is acceptance of the neurological criteria, especially by the family. Most of the time when we deal patients with families with brain dead patients, they have the concept that the child could revive back and maybe after some time they could again regain their life. So this is mostly because of the false media reports or how it has been portrayed in the movies. So we need to clear that concept that brain dead, usually it is actually the death of the patient. Then we need to talk about the consent for the testing. Again, this is a debatable question when we do apnea tests, whether we need to take proper consent. Most of the time we are not taking consent, but in some states, some laws, they are taking consent. So this is just a checklist for documentation of brain death, and this has been adapted from Stanford Hospital, and we are also using at some centers in India. So this is the picture I showed you at the initial of my presentation, a child awaiting for organ transplant with a hope of new life. And we had many success stories outside India. But I think we do have many success stories inside India also. And this is a 20-month-old youngest organ donor who, like few years back, who could save 5 lives from Delhi. And this is the miraculous child. And recently we also have the youngest heart donor from AIIMS Delhi, 2.5-year-old child. And the heart was donated to an 8-month-old congenital heart disease. So I hope we have many more success stories in pediatric as well as neonate, but I think pediatric brain death certification would just be an initial step towards it. Thank you.